Hi, everyone. Thank you for joining us for this presentation titled Strategic Insights into Navigating New Advanced Primary Care Management Codes and their synergy with RHC and FQHC care management updates. My name is Cassidy Ovula, and I'm the program coordinator for the Texas A&M Health Rural Engagement Program. We are recording this webinar, and we will share a copy of the recording as well as any handouts or slides that come up with you in a follow-up email. Our speaker today is Jen Tompkins with Revolution Health Solutions. Rayan Davis, the Director of Value-Based Care at the Texas A&M Health Rural Engagement Program, is also joining us today. And she might jump in here and there to provide insights and present some questions that we have received. So I would like to take a moment before we begin and introduce Jen. Jen Tompkins, the visionary behind Revolution Health Solutions, serves as its founder and CEO, advocating for a transformative shift in patient care within the healthcare landscape. Her core belief is that every patient deserves to be listened to, supported, and advocated for both within and beyond the confines of traditional medical settings. Acknowledging the shortcomings of intermittent provider engagements in managing chronic care illnesses, she strives to close these gaps by providing services that prioritize proactive rather than reactive approaches to patient health care. Jen also owns JBT Care Consulting, and whether it's launching a new care management program or reviving one in need, Jen provides comprehensive support and guidance every step of the way. We are honored to have you with us today, Jen, and you are a co-host, so it is all yours.
Audio. Thank you so much for having me today. I'm really looking forward to diving into this. A little bit, just quick update on my background. Revolution Health Solution was actually just acquired, so I'm no longer the CEO and owner. It was just acquired by a wonderful company known as Coach Care. So now I am a consultant and partner with them with the same exact goals in mind. So super excited to be with you today. And again, to dive into these new codes. Let me share my screen. Let me figure out the best where it goes. Okay. All right. Can you guys see that?
Yes, now we can.
All right. Perfect. So today, as I mentioned, we are really going to dive into these new advanced primary care management codes and the impact that they will have on our RHCs and our FQHCs. Within that conversation, though, we will also dive into CCM and chronic care management. We'll talk a little bit about what we do in traditional clinics versus RHCs and FQHCs. Because all of it really ties together. And I believe it's important to understand all aspects of that and not just, what this specific APCM. So we're going to talk about all of it, and then hopefully you will see how it all ties together. So we have been talking about APCM and these advanced primary care management codes coming out now for quite a while and how they are going to launch in 2025. And I can't believe that we're only a few weeks away now. I don't know about anybody else, but I feel like time is flying by right now. So we are almost there. All right, there we go. So as I mentioned, we are going to talk about APCM. We're also going to talk about chronic care management or CCM. In 2025, as a clinic, you will have the option to run either an APCM program or a CCM program or a combination of both. APCM will just be an added option. You cannot do CCM and APCM for the same patient at the same time, but you can do one or the other. And so again, we'll talk about not just, how that works together, but also when you might want to choose one over the other. We do believe that, before I move on, we do believe that APCM will fully replace CCM, principal care management, or PCM, transitional care management, TCM. We believe that those those services bundled together will be fully replaced by APCM in the future. But again, right now we're just putting our foot in the water and starting the process. We don't really know what the future looks like. We don't know what that bundling together will look like as we move forward and as it really fully takes over. So we're still waiting on that. Right now, we're just kind of going to start with some APCM options. So before we dive in to APCM, let's talk about chronic care management, because some of you on the call may be really interested in launching an APCM program, but for your clinic or for your, the makeup of your clinic, it may make more sense to do CCM. So we really do want to understand both. So CMS has been, or CCM has been around a long time. CMS introduced it back in 2015. It was the first time that providers were really able to be reimbursed for that non-face-to-face care coordination that was done outside the patient visit. At the time, though, it was all under direct supervision. So the provider had to be physically located where these services were being provided. The clinician needed to be in the office as well, or the care team. In 2020, CMS updated those guidelines for CCM and allowed it to be billed under general supervision incident to billing of the referring provider. We hear all the time from clients, from clinics, it doesn't matter who it is. We hear all the time, over the last few years, I feel like all these people are talking to me about CCM and RPM and these care management services, and there's all these software options, and there's all this technology, and there's all of, again, just opportunity everywhere. And why is everybody suddenly talking about it? And it really is from that 2020 change that allowed clinics to really better utilize these services, especially groups like our RHCs who internally sometimes didn't have the full staff to be able to run these programs or the full support. So it's been a really great addition. Since 2020, we haven't seen a lot change in CCM until these new APCM codes have come out. CCM services have always been for patients that have 2 or more chronic conditions that they believe will last, for a lifetime or for at least the next 12 months. One of the most important things, we can run services all day, right? We can improve outcomes. We can focus on quality, all the stuff that we're going to dive into. But it is incredibly important as the clinic to know how to bill for these services and how we do bill. So up through the end of 2024, this is how everything has been billed. Your traditional clinics have had the option to bill non-complex CCM codes and complex CCM codes. So 20, 40, 60 minutes of care, 90 minutes of care with a patient outside of, the office visit, those could all be billed at different rates to the payers, and you would get paid on that. Your RHCs and your FQHCs, on the other hand, as several of you know, you've been able to bill the GO 511 code. You have to have at least 20 minutes of care for that. But it doesn't matter if you had 20, 40, 60, 90 minutes of care, you got the $72. And that's these fees, by the way, that I have listed here, a few notes on this. These are your national average, about the national average rates for 2025. So some of you may go, hey, that looks a little less than what I've seen. Yes, we did notice that when the rates were released for 2025, they are a few dollars less in some cases. For different codes. Not a significant change, but just a little bit on both the CCM, and we saw it on the RPM side as well. One little thing I do want to note while I'm on this slide, because it is something we have learned from the backside and I work with people on all the time. And this is important for the RHCs and FQHCs, because heading into 2025, you will be able to bill these individual CPT codes as well. This GO 511 code is going away. We'll tell you a little more about that timeline here in a second. I'm going to move this. I've got something right in my line there. So it is important for everybody to understand these these time-based codes. Complex care versus non-complex care. I always tell any group I work with that if you are doing less than 90 minutes of care on a patient, make it non-complex care. There are a lot of different things you need to know and that need to happen for a complex CCM code to get billed. Not that it won't get paid, don't get me wrong, but truly if it got audited on the backside or something, could you truly prove that that was complex care that you were providing? All right. So I always tell people it is better if you're going to work with a patient between 20 minutes and 89 minutes that you are billing the non-complex CCM codes. And the good news is that in 99490 plus two 99439 add-ons reimburses higher than one 99487 add-on anyway by about $20, a little over $20. So just something to think about as if you are deciding, hey, we're not so ready for the APCM, but we want to do the CCM codes, the time-based codes, just something to think about as you do this. Again, RHCs and FQHCs have historically been able to build just the G0511. They have to do all the same elements, all the same requirements, just not getting reimbursed as well. The other problem with the G0511 is that it covers CCM, but it also covers behavioral health integration. There was no way to tell when these codes were being billed what services were actually being performed for the patient. It was really difficult to weed that out. So we're really excited about the 2025 updates from CMS. When we saw the new physician fee schedule come out, I know that plenty of us were celebrating some of these changes. So starting in January of 2025, our RHCs and our FQHCs will be able to bill, as I mentioned, the individual CPT codes for CCM services. So now you are getting paid based on time-based codes. You can include those add-on codes, and you'll report all of that on your UB04. There will be a 6-month transition period from January 1st, but eventually you actually won't be able to bill the G0511 anymore, and we believe that stops July 1st from what I've read. So they are giving you a period of time to transition away from that G0511 code for CCM, because not only, you may be able to transition away and go, well, that's not a problem, but softwares also have to catch up. Depending on what software platform you're utilizing, it may take a minute before some of those changes are made. If you are currently providing CCM services, though, I would be talking to the software company who, whether it's your EMR, whether it's an outside vendor that provides your software for these care management services, I would be reaching out to them as soon as possible and saying, are you all prepared for the fact that we can now do the individual CPT codes? And I'm going to leave plenty of time at the end of this presentation for questions and answers. So if you have any questions coming up, I know this can be a little bit confusing. Please write it down and know that I will do my very best to answer it at the end of this, but I've left plenty of time for that because I want this to be an open conversation here in a minute. All right, so let's dive into advanced primary care management. Now that we understand the CCM side and we're all on the same page there, let's talk about what APCM is. So APCM, Advanced Primary Care Management, is really driven towards your primary care providers. All right, it is really meant for your geriatric specialist, your primary care, your internal medicine, those that are taking care of the whole patient. It is a shift from get that time, bill for that time, just do whatever you need to get there, to a truly value-based care mindset. We want to really be focusing on quality and outcomes versus specific what timestamps we're meeting. I say it all the time. If you are saying that you provide CCM services for your patient panel, and really for those of you guys that do RPM, I know our FQHCs and RHCs might not be doing that yet, but you will be able to here in 2025. But if you are doing RPM as well, this holds true for all of it. If you are running any of these programs on a patient panel, or somebody is doing it on your behalf, and all they can come to you with is, your patients really love it. Patients love this service. Look, we've got 200 patients, 300, 500 patients on service, and your patient satisfaction has gone up incredibly. That's wonderful. We want improved patient satisfaction. That's definitely part of it. But what outcomes are you improving? What quality metrics are you seeing change because you are providing these services? So we always want to make sure that we're staying focused on goals and what interventions need to take place to meet those goals. What outcomes are you getting? Are there patients on service that are incredibly healthy and really don't need this type of care? We also need to be aware of that as well. All right. So I am excited to see things shifting a little bit more towards quality versus the amount of time being spent. These services can still be ordered and billed by physicians and non-physician practitioners, so your NPPs can order and bill for it as well. The payment model for it is based on the number of chronic conditions, not so much the time spent. APCM takes 3 different services and puts them all under one umbrella. So it bundles together, again, we talked about this here just a little bit ago, your CCM, your PCM, which is your principal care management. That, for those of you guys that don't know what PCM is, that is for a patient that does not have 2 chronic conditions. They have usually about 1 chronic condition. We have historically seen specialists really provide this program. Your cardiologist who only wants to follow for CHF or only wants to follow for hypertension, but doesn't want to see that entire picture. Whereas CCM, when you're providing CCM or APCM services, you need to be able to look at the entire patient. I always say you're looking at the patient from a helicopter view down, right? You're not just looking at that one chronic condition, but you're looking at how do all of their conditions affect their day-to-day living, their quality of life? How does their socioeconomic situation fit into that, or their psychosocial? You're pulling together that whole patient picture. TCM services. TCM are your transitional care management services. They are the 30-day. It's a program that is run for 30 days from the time a patient discharges from an inpatient facility to home or to another outpatient facility. So APCM is bundling all of this together. What you will notice is not under there is RPM. So you are able to bill RPM or BHI, Behavioral Health Integration, or CHI, Community Health Integration. You're able to bill any of that concurrently with APCM. But you cannot bill APCM and then TCM. Or as a practice, you can't bill APCM and then have the cardiologist also bill PCM. So for a patient in a month, they can only be billed for APCM, or they can be billed for really any of CCM, PCM, TCM. Those can all be billed concurrently for a patient. But it's similar to the way that we say a patient can't receive CCM services from Dr. A and Dr. B. All right. So just kind of think about that. So some of this will depend too, if you're looking to choose APCM, especially in our rural health areas, is there an endocrinologist or a cardiologist who works within that same area who is doing PCM on their patients, but you are the primary care and you want to do APCM? you may need to have a conversation with that other provider first because you may not know, or you need to make sure and really talk to your patients and confirm whether or not they are receiving these services. That said, not all patients know that they're receiving the services. Rightly or wrongly, there are patients that are not aware. If a patient doesn't know that they're receiving care management services, there's a problem somewhere, right? Because you have to get consent. You should have done a thorough care plan that involved the caregiver or the patient. So I'm not going to dive into my opinion on the fact that some patients don't know. But if you run this program and you're spending all this time and effort to do APCM or CCM, and somebody else is doing it at the exact same time for that same patient, then one of you is not getting paid. So just something to think about. And again, RHCs and FQHCs can bill for these APCM codes. Hopefully I'm not confusing everybody. Sometimes it's hard to give a presentation where there's no interaction. I hope this is making sense. All right, so APCM, unlike the time-based codes, here's how you bill for them. You've got your GPCM1, GPCM2, and GPCM3. All right, Tier 1, patient, I consider this more like your PCM. It doesn't matter how much time you spend with the patient in a given month. We'll talk about what you have to do, but the time, it doesn't matter as much. For a month, you get $10. I don't recommend running this program necessarily on a Tier 1 patient, right? $10, I don't know. You can make that decision on your own. I think $10 is an incredibly low reimbursement for that code. For your Tier 2, so your traditional CCM patient that has 2 or more chronic conditions, not based on time, but based on the care that you're doing each month, you can bill $50 for that pay for those patients every month. Tier 3, 2 or more chronic conditions. We've heard a lot of people say, well, most of our patients are Tier 3. They're real sick patients. They're high risk scores. They're all these things. There's a caveat, unfortunately. So the patients need to have 2 or more chronic conditions, and they must be a Medicare beneficiary that's dual eligible. So this is actually for your patients that are Medicare, Medicaid, or, that have the income issues, the income factors that play a role. So most of your patients, unless they are Medicare, Medicaid, which is if you've got a strong panel of that, then your Tier 3 is the perfect option for you. But your Tier 2 is really where most people will live. If you look at this and you say, well, wait, I want the G code back because the G code gave me $70. Or I want the 99490 back because it gave me more than this did. Yes, it does. It's something to really consider. It pays you better right now to do traditional CCM. But you really need a strong staff who has plenty of time, who can spend at least 20 minutes or more with every patient or working on behalf of every patient every month. For much larger groups that maybe don't have the same bandwidth, it's better to be able to take all 300 of your patients and put them, and I know I'm using 300, that's low or high depending on your clinic. Better to put 300 patients on APCM and meet that Tier 2 requirement than only be able to, with the staffing you have, put 100 of those patients on CCM services and be able to meet the 99490 or what we had before, the GO511. So it really depends on your office makeup. It depends on who the care team is providing these services. And remembering, we hear a lot of people say, well, I'm just going to stick with the 99490. Okay. Are you documenting and are you truly showing that you spent 20 minutes with that patient or on behalf of that patient every month? Or are you simply doing a quick check, doing something, and always time stamping something as 20 minutes? It's a big difference. I do believe audits will come out in more full force as we move forward. And so we always want to make sure that any time stamps, any time we have accounted for that we are billing for, our documentation really backs up that took us 20 minutes or 40 minutes or 60 minutes or 90, whatever you're looking at. The same holds true for any care management services you're providing. So just things to consider. But a lot of us are laughing at $10 for tier one. I don't know how that's possible. All right, so what are the required elements for APCM? In order to provide APCM services, these are the main elements that have to be in place. The ones that are bolded directly correspond with what you had to provide for CCM. But I would also say that most of these are things that everybody is already providing for CCM anyway. So that's why they're bolded. So you have to get consent of the patient. They have to have had an initiated visit with a referring provider within the last 12 months. They must have 24/7 access to the provider or a care team. I'm going to circle back to that because I get a lot of questions on that. They must have a patient-centered care plan that is electronic, right? That can be shared with the patient. So patients should always get a copy of their care plan. There should be that continuity of care, that care management oversight. One of the biggest parts of that is making sure that these patients aren't lost to follow up with you as the provider, or not lost to follow up with a referral that was made to a cardiologist or something else. Options for just an alternative care delivery method, which is really what these services are. We talked about just care transitions coordination. This is where your TCM, your transitional care management services, loop up underneath this. So if the patient goes into the hospital or they go into a rehab or they do something like that, if you are running APCM, then you are responsible for tracking that patient, seeing them once they come out, making sure that you have their discharge paperwork, making sure that really they're seen. I would still keep the same guidelines to say they really need to be seen by their primary care within those first 7 days of coming out of the hospital for med management and just touching base. Because we all know that if we can meet with them in those first week or so that they're out of the hospital and make sure that the meds didn't get confused, that everything's going well, we are going to have our best chance of them not readmitting to the hospital within those 30 days. Enhanced communication methods. So the ability to do a virtual call, a video call or something else. Sometimes we have apps that the patients can use. It depends on really the patient age, whether or not those work very well, but patients being able to communicate with somebody over an app or just having that go-to person versus calling the office and, the process that sometimes that goes through. Having ongoing communication with the patient, but really if you are working as, under general supervision, you're not located in the practice, then you also need to be having ongoing communication with the practice as well. Population, just being able to gather data so you can analyze, is this working, is this not? Risk stratifying, so saying these patients are high risk, moderate risk or high risk, especially for admitting to the hospital. We want to lower those hospital admissions. And performance measurements, again, just being able to prove that what you are doing is working. A lot of people said, but that's a lot. That's a lot of key elements I have to provide. You don't have to provide all of those elements in 1 month. You need to start with 3 big ones. Well, really 4. Every patient starts, they have to consent, right? You have to confirm that patient's had a visit with that provider within the last 12 months. You have to make sure the patient knows how to reach a provider or a care team member 24/7. And you have to complete that patient-centered care plan. Exactly the same thing I would tell you if you're launching a CCM program. What has to be done to start these programs are these 4 things. Everything else is part of what you will do ongoing with the patient, and you do a little bit here and a little bit there. I always say the best thing to do is decide what needs to be done for the patient and making sure that it gets done in that given month, and then moving forward again once you get them set up on service. 24/7 access to a provider or care team. The patient needs to understand how to reach the provider after like an on-call line after hours, know how to reach your care team during normal working hours. They need to understand when to call 911. So as I always tell patients, and I tell my team all the time, we need to make sure the patient knows how to get a hold of somebody that can help them in the hours in which, whatever time they need help. But at no point should we ever present ourselves as replacing emergency medical care. If a patient needs help at 2 a.m. in the morning and it is urgent, that is likely a 911 call. We are trying to do everything we can to keep these patients out of the hospital. Don't get me wrong. But if it's a true medical emergency, we need them to call 911 and go to the hospital. Period. We don't want to make that just, just go to the hospital and have that checked out if we are in the office and it's something we can look at and it's not an immediate concern. But if you're an outsourced clinical care team providing these services under general supervision, you don't need to have a 24/7 team. I'd actually tell you your attorney or your legal team probably wouldn't want you to, unless you're really, really high risk something and that's the way that you're set up. But the after hours on call with the provider or with the clinic, or 911 when it's needed. All right. Heading to the end of these slides. So important for both CCM and APCM, you've got to focus on preventative care. Okay. No longer do we want to be reactive in our healthcare system. We want to be proactive. So we want to focus on nutrition education, med compliance. I think anybody that works on this side of healthcare will tell you and will agree that more than 80% of issues that patients have are med compliance issues. They don't understand what meds to take. They forget to take their meds. They get a new med and they're supposed to get rid of another med. They're taking them both together. They're not taking the right dosage. They're not taking it at the right time. Whatever it is, med management, doing thorough medication reconciliations, not just by asking the patient, what do you take? But in a program like this, planning a time when the patient can put all their medications on their kitchen table and you can have a call with them and say, read off the names on the bottles and tell me when you take it. And that includes any vitamins you take, what other supplements do you take, really understanding, because some of that is unintentionally missed in their visits with their providers, and it can make a huge difference. Comprehensive care management, really setting solid, actionable goals, but then having interventions to meet those goals. If we are setting goals on a care plan and we're not looking at those goals for another year, I don't know if we're doing the right thing, right? You've got to show, are you working towards meeting those goals? What interventions are you providing to help you meet those goals? And some of the goals will definitely be more generic because a lot of patients need some of the same stuff, but every patient should have a few specialized goals, just specific goals just for them. So I always like to leave a little room to write in goals and not just have a full checklist. Care coordination, not just with the primary care provider, but also with specialists. Again, making sure they're not lost to follow up all the way around. And sometimes that care coordination is even with the caregiver. Improving patient and caregiver engagement, improving access to care for patients, making sure you're following documentation and reporting requirements, and using the technology that we have available. So the biggest takeaways are that a lot of this is really good news for FQHCs and RHCs. You can now have the option. You can choose to do CCM services and build those CPT codes. You can choose to do APCM if that fits better with your patient panel and the staffing that you have and the way things are set up. It allows you to care for more patients in a given month and do it effectively and efficiently. We aren't talking about RPM today, but we're really excited that starting January 1st of 2025, you will also be able, as an RHC or FQHC, to build the time-based codes for RPM. What I love about APCM, and again, RPM is going to be new for our clinics, but what I love about APCM is that if you are running a dual program for a patient, if you're doing both APCM and RPM, if they are a dual patient, I believe that in most cases, running APCM plus RPM makes the most sense. Because right now, when you have a dual CCM plus RPM patient, which you can easily do, or PCM plus RPM, I kind of use CCM and PCM interchangeably. You have to really watch for double documentation. You have to decide, where does this phone call count as CCM, or is this RPM? Or, hey, they had a CCM call, but does that count as my RPM interactive call for the month? There's different rules that are required for RPM and for CCM. There's a lot of confusion sometimes around double documentation or overlapping of time to meet a minimum of 40 minutes right now. If they are CCM and RPM, you have to show at least 40 minutes to be able to bill 20 minutes for both. APCM will really eliminate that issue, because a lot of your phone call and all that stuff will be RPM time versus APCM time, which will really just be done on the backside a little more. Don't misunderstand me. For APCM, you do need to be communicating with the patients as well. That's just a comment requiring your dual patients. APCM is also great. It will really start to improve the ability to utilize AI. We know that has to be worked into our EMRs, it has to be worked into our platforms that we use for care management, but there will be a lot more opportunities to utilize AI moving forward with the APCM model, which again, yes, you get reimbursed less, but your costs are less as well. You've got to understand the required elements for each program and understand how to correctly bill and get reimbursed, and you're good to go. There's a lot there. There's a lot to unpack, but I do want to just emphasize that there are those of us that are here to support you and help you make sure that you do this correctly and that you truly understand it every step of the way. All right. Questions and answers. So I'm going to end this and stop sharing. How do I stop sharing? I don't think y'all want to see my share. There we go. There you are.
Excellent.
I hope that I didn't just confuse everybody. I hope that was a good thing. And please know that those slides, I think, will be available, so you can look at them. But any questions?
Yes, we did have a couple of questions, and I see that Rayanne has responded to several in the chat. But I'm going to go back to the first question that came through. In 2025, still unavailable to bill for CCM if in PCF, but can bill the APCM codes. Is that correct? And if you've addressed this, I apologize.
Bill for CCM if in PCF.
So PCF, I'll just chime in. PCF is primary care first model. So there are different standards for APCM for PCF, and they do spell that out where that you do have some benefit and you can bill APCM. I am not sure about CCM. I know primary care first model is not a Texas-based model. It's not here in Texas, so not as familiar with it. But Jen, if you are.
Yes. No, because I'm in Texas. I don't know I don't know that I can answer that question perfectly. So but I can definitely look into that. And I don't know if there's a way that we can send an update to Brittany.
We can.
Because I'm happy to look into that for sure.
Yes. Okay. So Brittany, I'm going to share your contact information, and we'll try to get you a good response.
And let me just say, we were going to have a legal person on the team today, and she had an emergency and was unable to join us. She would have known the answer to that, which is why she was going to be here. So forgive me. Hopefully I can answer some of these for you guys.
Okay. And yes, we will be sharing the slides. And I think, Rayanne, you might have touched on the others. Let's see.
There was one question that just came in that I did not answer. It asked, what are the billing codes again for APCM?
Yes. So the billing codes for APCM, let me pull it up, you've got 3 tiers, but they are GPCM1, GPCM2, and GPCM3. They're G codes.
Okay,
And
go ahead.
I think there's another question that came in, but before we go to that question,
yes, so you can easily do a combined consent. You just have to have patient consent. And so we see people do combined consent for CCM and for RPM already, or for BHI and, CCM or BH, whatever. So yes, I can't see any reason why you couldn't do that. But I would say that you need to know whether or not the patient's going to be billed for APCM, or like that patient needs to be an APCM patient or a CCM patient. I wouldn't change it month to month. That's probably not something I would recommend. I would say these are the patients that we will see as APCM patients, and these would be our CCM patients if you plan to run both programs simultaneously. I wouldn't plan to make that decision at the end of the month if you just don't meet your time, because you really do have more elements, just a little different factors that have to be met per program. And so one would be APCM and one would be CCM. The other thing to really keep in mind too is that because PCM, CCM, and TCM cannot be billed concurrently, if you've been billing, just say PCM on a patient, and now you want to do APCM, you need to make sure, if you're not their primary care provider, that somebody else isn't billing one of those services for them. Because if you bill APCM and somebody else bills CCM, one of you are not getting paid. Or if you bill APCM and somebody else bills, that patient goes into the hospital and comes out and they bill TCM, you're not getting paid. Or maybe they're not getting paid, but I always feel like it's us that don't get paid. I don't know, I feel like we're always on the wrong side of that somehow. So, but if you run a pure CCM service, then somebody else, another specialist or something that's working with the patient, can do PCM concurrently or can do TCM if they needed to.
Ryan, were you going to comment on something?
yes. Do you mind elaborating on what type of care team staff can operate APCM or CCM? Do they have to be clinical?
So preferably they are clinical, right? But anybody working on behalf of that patient in a given month can bill for APCM or CCM. There's a caveat. You really need a clinical team member to be the one that creates the initial care plan for that patient. It's just best practice. Ideally, it's a nurse or an LVN that is creating that comprehensive care plan alongside that patient or that caregiver, that initial one. But as far as who is checking the chart to see if they followed up with their visits, to make sure, hey, they saw the doctor and the doctor sent a referral over, let me make sure it's gone through, or the patient calls in and needs something with their medications and you're doing something like that, all of that can be billed by whoever is having that conversation or working on behalf of the patient in a given month. It is always best to run these programs with your certified clinical care teams, but that could be an LVN, an RN, it could be a certified medical assistant. I know that our team, we have several certified medical assistants. They don't do our care plans, but they do a lot of the month-to-month interaction at times, and they're fantastic. I mean, there's some amazing team members that we have that work on that. But sometimes you just have a clinical assistant that is handling something as well, and they can be billed. As long as they have been trained by the office, as long as they're being overseen and that supervision is happening. Again, it can still be general supervision, but you really want to make sure if they're not clinical, that they're really well trained, because you really do want to have these more in-depth medication conversations with these patients. You want to be able to talk about nutrition education, lifestyle management, community resources, different. That's all the stuff. I mean, if they can handle that kind of stuff, then they can do it. But again, 2 or 3 people can put time towards CCM in a given month, whoever is working with that patient at that time. I hope that answered that. Did I confuse everybody so much that everybody's just really quiet?
There's a couple more questions that have come in. I'm glad there's a lot of discussion going on. I think this is follow-up from your last question. Can there be if the patient is in APCM, would the coinsurance be the same as if they were in CCM?
So that is something we are still waiting to hear how everything is paid. But yes, I mean, I think my billing team is actually on this call. So I should be able to answer this really well. My husband owns a billing company, RCM company, so I'm always embarrassed if I don't know the answer to these questions. But yes, somebody on the billing team speak up if I am wrong. But your coinsurance, what your primary insurance doesn't pay, the coinsurance should still pick up. So that shouldn't be an issue, just like any other service that's being provided. So nothing is better on these programs than finding your patients that have a primary and a secondary insurance. It's really hard for a patient to say no to something if you're like, this isn't going to cost you anything. It's covered.
There was an additional comment, which is, I love this conversation between billing APCM versus CCM. But say you have a lot of time spent on that patient for that month. And a prior month they were in APCM, but now this month you've spent 60 minutes or more on that patient. There might be some benefit to switching over to CCM. Any thoughts on that piece?
So I think that's how it all sort of levels out, very honestly, with APCM. And I will be interested to see if over time, as the CCM codes may go away eventually, if APCM reimbursement becomes better, it's going to have to get a little better, I think, if they're going to get rid of the CCM codes just based on time. But you have to realize that if you take, y'all have to pull out my thing. If I take 200 patients with 20 minutes minimal a month, let's just start there. So that's 4,000 minutes that somebody has to spend in a month to be able to build just one initial code for your CCM patients, right? Versus if I can say that most patients take an average of 8 minutes per month after that first month, that's 1,600 minutes a month that I need to spend to be able to build that APCM code. And so I don't know if the way that word to my mind came out right, but you're going to have months with certain APCM clients where you are going to spend 40 minutes, or you are going to spend 60 minutes, especially at the very beginning, right? Anybody that has done CCM knows that you're not onboarding and doing a care plan and doing all that in less than 20 minutes. Really in less than 40 minutes. Usually that is a 40 to 60 minute process minimally. But the months after that, you may be checking and helping them follow up on a referral, and it may take you 6 or 7 minutes, and you send them an email to check on something and you communicate with them. Your total time spent was 8 minutes, but you're still able to bill that code, that $50 code, right? Or if they're a dual eligible Medicaid, Medicare, you got the $110. It will offset the months where you spend a lot more time. But yes, if consistently you are spending 40, 60 minutes because we all have those patients, right? That call about everything. They need something all the time, and they really need that constant communication. I would just permanently switch them to CCM, and that's fine, but I wouldn't jump back and forth. And I would just understand that, yes, you're going to spend more with some, others with that, but the fluctuation should really level itself out. Because we do see a lot of clinics, and I'll be honest, we see a lot of clinics from the backside as we go in to try to help people or work on things where all the patients that qualify are getting a 20-minute timestamp for something that was done in the month. I know the reimbursement is good, but as audits come through and come out, I wouldn't want to be on the backside of that audit.
Another question came.
What you're doing. Yeah.
Another question came in. What's your opinion on the best way to identify the qualifying Medicare beneficiary status of the patients? And maybe if you could re-highlight why that's important when you're doing
Yeah,
APCM?
so in order to bill for the tier 3 GPCM3 code, which is $110 reimbursement per month, that is going to be any patient that is dual Medicare, Medicaid. It is based on income status. Because we all know, not all patients, but those patients with lower income status, they don't have as many access, they don't have the access to the same resources or the same nutrition. They can't always afford the meds, right, that are being done. Those patients, you are going to spend more time on, and they will need more. They tend to be the ones that go into the hospital more frequently. And so the reimbursement for that is $110. Your EMR, I hate to say that as a blanket statement. Most EMRs, you can pull a Medicaid report, and pulling maybe a Medicaid report would help you start in that process. It all depends on what EMR system is being utilized by the clinic and where you can pull a type of reporting that would show you. It's not always perfect. Sometimes you got to have somebody that kind of says, hey, they're over this age and they've got this and they've got that. I got to kind of have somebody that's qualifying going through those charts. Let's look at a section of patients and just go through each chart and see, are they Medicaid? Or when they come into the clinic, obviously you're looking always at what their insurance plans are. Somebody is, the front desk, the person on the backside, set up a process where they are tagging any of those patients that are Medicare, Medicaid. But I hate to say it's EMRs because there's plenty of EMRs that don't do it well. It can be really confusing. I would say the best option I would have is to try to do it through your EMR first. And if you can't do it through your EMR or some reporting that your clinic or your system has, then it needs to be something that is either gone individually, or as those patients come in, you're just enrolling them in real time.
Yeah, that's great. And I think
Not
just to add
all
on
people
that,
eligible or qualified because of low income component. So I do know that there's a low income component. The only thing I have seen so far is that they are Medicare or Medicaid. But that's something to definitely look into. There's still so much to learn, and I'm not going to pretend to be the expert in all of it. I wish I knew for sure. But again, that's something else that I can look into, is what would be the way of really looking at that and pulling that.
and I would just add to that, because it is very complex, but if you are part of an ACO or ACO REACH or those programs, they have data sets that might help you enhance that list.
Yes, definitely. If you have an ACO that you're part of, talk to them.
I don't see any other questions in the chat, but we did have a question that came in during registration. And again, if you've addressed this, I apologize, but it stated, is there a quick reference to help providers find and use RHC modifiers?
Yes. I mean, I know there is. Again, let me get that. Is there a way to get emails from these people that are asking these specific questions so we can get back? Because I really want to answer these questions perfectly for them. I'm wondering, trying to loop somebody in.
Yeah, we can definitely grab their email addresses. We have that from registration, and then we can follow up.
Yeah, because I can definitely get these answers pretty quickly, but I have an idea, but I don't want to speak wrong to that. Makes me feel better because I don't think my legal counterpart could have either.
We miss her, but it's been excellent. Okay,
Yeah.
let's see. Anything else? Rayanne, did you have any other questions on your end?
Yeah, I don't, but if you're looking through them, I wanted just to add that as part of the Texas A&M Rural and Engagement Program, we do provide technical support, and through that support, we offer services that support value-based care, as well as chronic care management, these new APCMs, remote patient monitoring. So if you need additional support, you want to have additional conversations, please follow up with us, and happy to engage with you. The Rural Engagement Program is specific to Texas rural counties.
Yeah.
And it is at no charge.
Yeah, that's what I was about to add, Rand. Yes, if you are a rural hospital clinic provider in Texas, there is no charge for the support. I did drop 2 links into the chat. The first one is just the link to our website. The second one is our technical assistance inquiry request form. So as Rand said, if you're interested in learning more about that support or what we do and how we can support you, just click that link. It's just a couple of questions and then we'll reach back out to you and follow up.
And just a quick addition to the question about the modifiers for RHCs. My billing team has texted me. They are looking into it and should be able to pull a report, find something on that to share. So we should have that soon.
Great. That's perfect. So we'll get that to you. Okay, let's see. I do want to do one thing. I just launched a poll. It's 4 questions. If you would just take a moment to click through that, we would really appreciate it. And then, as I stated earlier, we'll get the resources out to you and we'll follow up on the questions. And I don't see anything else in the chat. So I think we'll go ahead and go. But thank you so much, Jen. It was a very informative webinar and we're so glad that we could have you back with us. And thanks to you as well, Rayanne, for being here and chiming in and supporting the webinar.
Yeah, thank you guys for the great questions. I agree. It is, I'm sorry I couldn't answer them all, but definitely gives us something to also look into to know what you guys are looking for so we can get back to you on certain things.
Yeah, absolutely.
And maybe future webinars.
Yes, that's a good idea.
And also, if you're an RHC or an FQHC, RPM is coming too. So that's really exciting. So
Yeah.
you have there's some really good news in the new fee schedule. So we're excited about it.
Absolutely. Thank you, Beverly. Thank you for that comment. So we will adjourn. And thank you so much for your time, everyone. Thank you for joining today. And hopefully we will see you next month. Bye, everyone.
Bye, guys. Thanks.